Welcome to our webinar today. It's about hypothyroidism and pregnancy, and thanks for joining us. I am Gabriela Brenta, Chief of the Thyroid Division at the Dr. Cesar Milstein Hospital and Assistant Professor of the Medical School of University of Buenos Aires, Argentina. These are my disclosures. And our learning objectives today are to understand how and when to test for hypothyroidism in pregnancy and the importance of prompt treatment, to competently manage hypothyroidism in pregnancy and plan and deliver postpartum screening programs for hypothyroidism. First, let's welcome our faculty, our invited speakers, Dr. Christian Bullard. She serves as president of the British Thyroid Association. She's professor of endocrinology at the University of Birmingham, UK. And Dr. Tim Korevaar, he serves as an obstetric internist and endocrinologist at Erasmus University Medical Center, Rotterdam, the Netherlands. We also should acknowledge our partnerships and endorsements. We are endorsed by the British Thyroid Association and the Latin American Thyroid Society. Our agenda today includes the two presentations, the first one by Christian Bullard, Hypothyroidism Before and During Pregnancy, and Dr. Tim Korevaar will speak about hypothyroidism in pregnancy, the bigger picture. After those presentations, we'll have a panel discussion. This program has been accredited by the European Accreditation Council for Continuing Medical Education and certified by the CPD Certification Service. Please complete the post-webinar survey at the end of the webinar on our e-learning platform to download your certificates. We also have to remember that we have simultaneous translation. Please select your preferred language on the webinar page, either English, Spanish, or Chinese. For questions and answers, please submit your questions during the lecture in the questions and answers section. The faculty will address your questions during the panel discussion at the end of the webinar. And we kindly ask you to complete the pre-webinar survey in case you haven't done it on the media learning platform. And here is the direct link, which will be also available at the chat. This educational program is made possible thanks to an independent educational grant received from Merck Healthcare, Darmstadt, Germany. And now I shall introduce Dr. Christian Bullard for the first presentation.
So thank you for that kind introduction, and thank you for asking me to speak here. So the first part is going to look at managing overt and mild hypothyroidism before and during pregnancy. Oh, sorry. Oh, there we are. So I have no conflicts of interest related to this presentation. And the learning objectives for today are that I hope you will, after this session, understand how to manage overt hypothyroidism in pregnancy, discuss the consequences of mild hypothyroidism, both on the fetal outcomes as well as on pregnancy outcomes, and to understand the management of euthyroid TPO antibody positive women, both in fertility and pregnancy. So the data we have on managing overt hypothyroidism in pregnancy are more than 20 years old. And with an increase in women receiving thyroid function testing, we are finding more and more women who do have abnormal thyroid function. However, it's only a small proportion of women who have a serum TSH that's greater than 10 millunits per liter for the first time in pregnancy, and the estimated worldwide prevalence of this is only 0.15%. It is likely that mild abnormalities to thyroid function are related to true overt hypothyroidism. And we know that the majority of gestational overt hypothyroidism is mild, and Tim will come back to this, but interpreting thyroid function in pregnancy, as well as a number of other problems, can result in falsely low free T4 concentrations. And a further thing which Tim will focus on is that there is spontaneous normalization for a large proportion of women who are found to be hypothyroid in pregnancy. However, if someone is known to have overt hypothyroidism and is treated with levothyroxine, then this is the algorithm that certainly we have used in our clinic, and I think that reflects what's in most guidelines. You should aim for an adequate preconception replacement with levothyroxine with its target serum TSH range of less than 2.5. And what I tell women to come to my clinic when they're planning pregnancy or women of childbearing age is to empirically increase the dose in early pregnancy. And generally, they need a 20 to 30% increase to overcome the increased demands of pregnancy. And the easiest way to do that is to tell them as soon as you find out you're pregnant, double the dose on 2 days of the week, usually during the weekend. Regular monitoring of thyroid function testing, ideally 4 weekly until 20 weeks, and then once again at 28 weeks, helps very much in keeping this well controlled. And what we do is predictive dose adjustment. So I don't wait for thyroid function to become abnormal. Once TSH approaches the upper end of what I would consider the target range, I make changes to the levothyroxine replacement. And I tell them to reduce it 2 weeks postnatally, since the increased levels of binding proteins remain present for a couple of weeks after delivery. So just a brief word on isolated hypothyroxinemia. I think this audience is probably well aware of what this is, but this is a unique situation in pregnancy and affects up to 2.2%. It is not entirely clear what causes this, but a number of links have been postulated. It's been linked to iodine deficiency, iron deficiency, higher BMI, greater age, and is also more common in twin pregnancies. A lot of this relates to the way in which free T4 assays perform during pregnancy, but essentially what you have here is a low free T4 with a normal TSH, which outside pregnancy would reflect pituitary dysfunction, but not in pregnancy. It has been associated with a number of adverse outcomes, including premature rupture of membranes, gestational diabetes, and a number of others that are listed there. And it's also been linked to a number of adverse neurocognitive outcomes. However, there is no evidence from randomized controlled trials that treating this condition with levothyroxine improves either obstetric or neurocognitive outcomes. And therefore, treatment of this condition is not recommended in any trimester of pregnancy. So looking at a number of adverse obstetric outcomes that have been associated with mild thyroid hypofunction. So this reflects both subclinical hypothyroidism and isolated hypothyroxinemia. And the first outcome I'm looking at here is preterm birth. So these are data from Tim's consortium in pregnancy. This is one of the largest studies we have, bringing several cohorts together, indicating that both in subclinical hypothyroidism and isolated hypothyroxinemia, there is a signal that this is associated with preterm birth. But when you look at the maximum absolute risk difference for preterm birth compared to those women who are euthyroid, this is only a 5% to 7% increase. And then if you look at very preterm birth, so this is gestational age less than 32 weeks, again, you see a very small maximum absolute risk difference with these mild forms of hypothyroidism. It has also been linked to small for gestational age babies. And you can see here again data from the same consortium indicating that with higher serum TSH, there is an increased risk of having smaller babies. And indeed, when this was analyzed in a linear manner, per one standard deviation increase in serum TSH, there was a 4-gram weight loss in the baby and in the offspring. But again, when you look at the maximum absolute risk differences, this is only, compared with euthyroid women, this is only a 10 to 11.8% difference. Looking then at preeclampsia, which again has also been linked to these mild forms of hypothyroidism, both subclinical hypothyroidism and isolated hypothyroxinemia. So with TSH, you get this U-shaped curve indicating that both low and high levels have been implicated with preeclampsia. But again, when looking at the maximum absolute risk difference, this is relatively small and only goes up from 2.1% in euthyroid women to 3.6%. So Of course, a number of these factors and associations are very relevant to women who are seeking fertility, and especially those attending our fertility clinics or who have recurrent miscarriage. So as I've already illustrated, we know that subclinical hypothyroidism has been associated with an increased risk of miscarriage, preterm birth, preeclampsia, and perinatal mortality. However, the association with subfertility remains conflicted, and there is insufficient evidence to suggest that subclinical hypothyroidism causes subfertility. We know that women with subfertility have higher TSH concentrations, and certainly those with a serum TSH that's above the reference range are associated with lower fertilization rates. There is no association between subclinical hypothyroidism and recurrent miscarriage loss when this is defined by non-consecutive pregnancies, although there may be an association when you look at consecutive recurrent miscarriages, which requires further investigation. However, taking all these data together, there is no strong or consistent evidence for an association of TSH values that are in the upper half of the normal range with adverse fertility or pregnancy outcomes. And what about if we treat these women then with levothyroxine? So those are women with mild hypothyroidism who are treated with levothyroxine. And again, here what we have are data from a meta-analysis that was performed. And this looked at pregnancy loss rates and preterm birth rates. And you can see that there was a signal, a mild signal for an increase in pregnancy or a benefit in pregnancy loss rates, but not for preterm birth rates. So there are some data, however, many of these populations are very disparate and there are mixed study types. And when you look at the number of events here, there are really quite low numbers of patients that have been included in this. So again, not consistent evidence that treating subclinical hypothyroidism in the fertility population results in better outcomes. And then the further aspect we need to consider is what happens to IQ in the offspring. And of course, we had the original data in 1999 indicating that hypothyroidism is associated with worse child IQ outcomes. And a number of studies have since been performed. And again, here, this is a nice meta-analysis that was performed. There are actually quite a few patient and children pairs that were included in this, but there was no consistent evidence that subclinical hypothyroidism was associated with a lower IQ. And again, when free T4 was analyzed linearly, you can see that indeed low free T4 concentrations are probably associated with a lower point IQ. And a previous study had shown that maybe this was also true for higher ones. But again, when you look at the maximum effect, this is a maximum 4-point IQ score difference. And indeed, in this arena is where we have a number of nice trials. Three main studies have been performed, 3 trials, which treated women with subclinical hypothyroidism or isolated hypothyroxinemia with levothyroxine, and then studied neurocognitive outcomes in the offspring at various ages, but generally between 3 and 5 years. We have the NIH trial, the CATS trial, and then studies from Iran, which are combined here. So one of the first things to note is that actually the replacement treatment, certainly for these top 2 trials, was quite late. So in the CATS trial, it started at 13 weeks, in the NIH trial at 18 weeks. And there was no positive effect here. So there was no effect on neurocognitive outcomes. You have to bear in mind that some of the criticism here is that this was probably started a little bit too late. The only study that was started at 12 weeks, which arguably is still a little bit late, showed that there was a signal of a lower preterm birth score and a better motor score. And then, of course, what I used to tell lots of my patients in clinic was, well, I don't really have any good evidence that giving you levothyroxine is going to result in better outcomes, but I'm probably not doing any harm. And what I'm going to show in the next few slides now is that there is some signal that possibly there is some harm by giving levothyroxine. So this is a database study. This is 5,000 women with subclinical hypothyroidism who were treated with levothyroxine. And you can see that treatment with levothyroxine, what's indicated in green, is that there is an increase there is a beneficial effect on pregnancy loss, But on further analysis, there were actually negative effects on preterm delivery, gestational diabetes, and preeclampsia. And this was one of the first signals that we got indicating that maybe overzealous levothyroxine replacement in these women may also be associated with adverse outcomes. Looking then at child IQ and behavior, I've already shown you, so I'll take you to the right-hand side of the slide first. So these are data, follow-up data from the CAT study, where quite a high dose of levothyroxine was started. So those women were started on 150 micrograms of levothyroxine, which really is quite high. And on further analysis, what was seen, certainly in those women who were overtreated with levothyroxine, was that there was an increased risk of ADHD in the offspring. And again, here, these are data from a Danish database. What you can see is an inverse U-shaped curve with free T4 towards the lower end and towards the higher end of normal being associated with worse verbal IQ outcomes. And subsequent studies have shown that these high free T4 concentrations are associated with autism, ADHD, as I've already shown, and epilepsy in the offspring. So pushing that serum free T4 towards the higher end or even above normal may not necessarily be without harm to the offspring. So these are data that are still under consideration and form part of the draft of the new guidelines of the American Thyroid Association. And of course, you have to remember that the previous guidelines indicated that in women with a serum TSH, they're very much divided depending on their TPO antibody positivity. And in those who were TPO antibody positive, that a serum TSH over 2.5 would be considered for treatment. In this guideline, and based on all those most recent data that I've shown you, it is very much divided by trimester. So if serum TSH is normal, so this is the full normal range, up to generally about 4 milliunits per liter, we would not treat. If serum TSH is above the upper limit of the pregnancy-specific reference range, but less than 10, consider treatment in the first trimester, and definitely treat in women with a serum TSH over 10. If they present later in pregnancy, in the second or third trimester, then what we say is that there is no treatment recommended, even if serum TSH is above the upper limit of normal. Of course, bearing in mind that this 10 milliunits per liter is not a hard cutoff, and that also this transition between first and trimester is not a hard cutoff, and individualized decisions have to be made. Looking then finally at euthyroid TPO antibody positivity. So again, we have known for some time that having TPO antibodies is associated with adverse outcomes. And again, these are data here from the consortium on thyroid in pregnancy, looking at preterm birth. And you can see that those who are TPO antibody positive, that is associated with an increased risk of preterm birth. And this is particularly so when serum TSH is greater than 4. But again, looking at maximum differences between TPO antibody negative and TPO antibody positive women, this is actually quite a small difference in relation to preterm birth. So again, there have been a number of studies here looking specifically in those women seeking fertility and those attending fertility clinics. And what's been looked at is the rate of miscarriage and live birth rate. And this is quite a nice systematic reviews. For the miscarriage rate, this included 21 studies, and there was a significantly higher miscarriage rate in those women who had positive antibodies, and a significantly lower live birth rate in those who were positive. So a signal here from those retrospective studies that having TPO antibodies is associated with worse outcomes. And a number of other large systematic reviews and meta-analysis have also confirmed this. And again, in this arena, what we now have are 3 very nice trials that have investigated this. They're all slightly different in their own right. The first one was in women seeking assisted conception. So these are women undergoing IVF egg transfer, and the primary outcome here was less than 28 weeks. 600 women were randomized to either placebo or to receive levothyroxine, and this was a negative trial. There was no difference in this primary outcome of miscarriage rate miscarriage before 28 weeks, but so both early and late miscarriages were no different whether you gave levothyroxine to those women who have positive TPO antibodies but have normal thyroid function. And a number of secondary analyses, again, were negative. The second trial is the tablet trial, which I was involved in. So this is a trial that took place in the United Kingdom. So this was women who had a minimum of 1 miscarriage or were seeking fertility, who had subfertility. And what we did was we randomized 960 women to receive either levothyroxine or placebo, and our primary outcome was live birth at greater than 34 weeks. And again, this was a negative trial indicating that giving levothyroxine to those TPO antibody positive euthyroid women did not affect this outcome. And you can see here a very large number of secondary outcomes that also were not affected by giving levothyroxine. A number of subgroup analyses were undertaken, but particularly what I want to focus on is that you can see that there was no difference by giving levothyroxine to those who had multiple miscarriages. And then here, this very thorny issue of a serum TSH greater than 2.5 or less than 2.5. And again, there was no difference. And there was no difference whether women underwent assisted conception or not. What we did following the tablet trial was look at what happens to those women who have positive TPO antibodies but have normal thyroid function. And so we followed them up, and indeed about 8% of those who took part in the trial developed hypothyroidism during follow-up. This was subclinical in the vast majority of them, but overt in 10%. And in those women who were randomized to receive levothyroxine, we found an increased rate of new onset thyrotoxicosis. Again, probably not surprising. Luckily, 80% of those who developed thyroid dysfunction did this within 6 months of enrollment, and the vast majority pre-conception. And if this was during pregnancy, again, we caught most of those women in the first trimester, so at about 6 weeks, with fewer women developing this later on. Those who had higher titers of TPO or higher TSH concentration were more likely to develop hypothyroidism. And when we looked at the outcomes, there was the failure to conceive rate was higher in those women who developed hypothyroidism, but our primary outcome of live birth rate was similar. And then the final trial I want to highlight, so this is Dutch trial. This is called the T4 Life trial. Here women needed a minimum of 2 pregnancy losses. And again, 187 women were randomized to receive either levothyroxine or placebo. And here the primary outcome was live birth beyond 24 weeks. And you can see that both the placebo and the treatment group are superimposed. So again, indicating that the routine use of levothyroxine cannot be recommended in these TPO antibody positive euthyroid women. So my take-home messages are that overt hypothyroidism requires dose adjustments and regular monitoring, especially in early pregnancy. The absolute risks of subclinical hypothyroidism in relation to poor pregnancy and neurocognitive outcomes are really quite small. And what the studies have shown is that treatment of isolated hypothyroxanemia is not recommended at any point in pregnancy. You would consider treatment of subclinical hypothyroidism in the first trimester of pregnancy. There is no RCT evidence that giving levothyroxine for mild hypothyroidism improves neurocognitive outcomes. And there is, again, good RCT evidence that treating euthyroid TPO antibody positive women does not result in improved fertility or pregnancy outcomes. And I've also shown you some data that overzealous levothyroxine replacement is not without risk. Thank you very much.
Thank you very much, Kristen. Well, now let's move to our second presentation by Dr. Tim Korevar.
Thank you, Gabriella, and thanks to the organizers for inviting me to speak at this webinar. So in light of the very interesting new things that Christine has shared with you, I was asked to also talk a little bit about screening and about pregnancy reference intervals. And pregnancy reference intervals are, of course, very relevant for the interpretation of TSH and free T4 measurements during pregnancy. And then I also have one slide to give you an update on postpartum care for hypothyroidism that was diagnosed or treated during pregnancy. So let me just go to the learning objectives here that you can read on the screen. And let's just skip over to the first bit, which is where I wanted to discuss screening and pregnancy reference intervals at the same time. And the reason for this is because I want to show you that screening and also reference interval definitions are very much intertwined. So you can't see one without the other. And that's, of course, because differences in reference ranges really affect how we diagnose thyroid disease in pregnancy. And it's that diagnosis that then, of course, also leads to treatment and potential risks related to overtreatment. So again, like I said, these two things are really intertwined. So what I'm going to try to do now with the first couple of slides is confuse you as much as I can. And then after that confusion, I will share with you at least what my view is on screening in general and deciding on reference ranges in general. So most of you will probably know this. This is a brief outline of what you can extract from the current American Thyroid Association guidelines when it comes to defining reference ranges. And that is that in the first place, they recommend you calculate reference ranges in your own hospital. The second option would be to use reference ranges that have been calculated in a hospital that's very similar to your hospital, and at least also use the same TSH and preferably also 3T4 assay. And then if that is also unavailable, you can have a fixed upper limit of TSH that's 4 milliunits per liter. And one of the things that also pops up in the current guidelines is that you can deduct 0.5 milliunits per liter from the upper limit of normal that you use outside of pregnancy, right? So those are two sort of alternative approaches. Now, one problem that remains is that the current guidelines don't give you any guidance on how to interpret 3T4 concentrations. And the reason for that is best illustrated by some data from our consortium showing the histograms, so the distributions for TSH concentrations in different hospitals and 3T4 concentrations in different hospitals. And what you can extract from this is that with a reasonable certainty, you can make an upper limit of TSH for interpretation in pregnancy, but for 3T4, the assay differences and the effects that pregnancy physiology has on those measurements is all over the place. So you can't give any recommendations with regards to absolute or relative differences compared to your non-pregnancy interval. So how to deal with this? Well, I said I was going to confuse you, so bear with me for a little bit. One thing that we've recently studied again in our consortium was the difference between calculating hospital-specific reference ranges and using those alternative approaches that you can see here on the left. So using 4 milliunits per liter as the upper limit, or subtracting 0.5 milliunits per liter from the upper limit outside of pregnancy. And we found quite large differences in both the first and the second trimester when it comes to diagnosing hypothyroidism, so both overt and subclinical hypothyroidism. So if you compare those alternative approaches to the approach of calculating hospital-specific reference ranges, with the alternative approaches, we see about 30% overdiagnosis and more than 50% underdiagnosis for overt hypothyroidism in the first trimester, shown here in the red circles. And that is, of course, the most important thing that we do want to identify when we see a patient for the first time in pregnancy. So really large differences. So what does this actually mean, right? This percentage? Well, I think that's best explained according to this slide here, which shows you 1,000 pregnant women. And when we would screen every woman for thyroid function when they present in pregnancy, the colored coding here show you the number of women that we would identify with an abnormal thyroid function test. And in red, you can see the 5 women out of 1,000 that we screened that we would identify with overt hypothyroidism. So very small number, right, relatively to the number that you need to screen. Here I've zoomed in on the women with an abnormal thyroid function. You can see also in yellow, there's a large group of women with subclinical hypothyroidism, which really far exceeds the women with overt hypothyroidism. And then just for reference, also the other abnormalities that we can encounter. So out of all the women that we find, the 5 women with overt hypothyroidism, then one of those women will have a TSH above 10, right? So that's the group where we're really sure they have true hypothyroidism that we should treat and that probably have a high risk. Now, one of the most important things when it comes to screening is that we don't really know which of these women we would actually also identify if we perform a risk factor-based screening, right? Because the studies that we have comparing risk factor-based screening to universal screening aren't that great. And most of the risk factors that are investigated in those studies aren't actually complete. So there's a lot of data missing, for example, on whether women have type 1 diabetes or autoimmune diseases, for example. So just to go back to this picture, we'll only identify a very small proportion of women that we really want to treat, right? If we start to screen all of these women that see us. But when we go back to those discrepancies between using your hospital-specific reference range or the alternatives, it's important to realize that when we do a thyroid function test and we find overt or subclinical hypothyroidism, we always think that what we are identifying is actually true disease. But considering the differences with the alternative approaches that I showed you, what it comes down to actually is that out of the 5 women we consider to have hypothyroidism, only 3 of those will truly have hypothyroidism if you use hospital-specific reference ranges. We're overdiagnosing 2 women, and we're missing to identify another 2 women that actually have overt hypothyroidism, but that do not fit within the alternative method reference ranges. On top of that, we now have some additional data from 2 studies, which actually show us how many women that we identify as having either overt or subclinical hypothyroidism with a test at early pregnancy that also still have it without treatment when we recheck thyroid function. So this says something about the natural course of hypothyroidism in pregnancy, and this also of the persistency of overt or subclinical hypothyroidism if you retest it. These numbers here are from 2 studies. The first column is from a Danish study where they looked at thyroid function at week 7 to 8 and then again without treatment around week 11 to 12. And they found that 40 to 45% of women with either overt or subclinical hypothyroidism remain to have overt or subclinical hypothyroidism at week 11 to 12. So the persistency was very low, and more than half of the women without treatment no longer had an abnormal thyroid function. And in a Chinese study where they looked at the difference in without treatment between the first and the third trimester, these numbers were even higher, as you can see. So those numbers show that for overt hypothyroidism, less than 5% still had overt hypothyroidism in the third trimester, and this was about 25% for subclinical hypothyroidism. So if you would then take this into account, again, with considering who we feel have true disease or who have over or under diagnosis, the numbers are actually more more different than you would want them to be. So actually, if you take into account the persistency of disease, only 1 out of the 5 women that you think have hypothyroidism truly have hypothyroidism that also persists without treatment, and we're overdiagnosing 4 out of 5 women. So what this comes down to is that there are so many uncertainties left in how we are all diagnosing an abnormal thyroid function during pregnancy, that if we would say that everybody has to be screened in pregnancy, the differences between the centers and compared to what we consider the gold standard, so the calculation of your own reference ranges, is so large that the outcomes of the screening will be so different across the world that on top of the other arguments against screening, screening really doesn't seem to be a good idea with the current knowledge that we have. So this was the confusion bit. Now let's give you a little bit of grip on how to deal with these things. This is mostly based on expert opinion within the reference within the ATA guideline committee group and my own opinion. So for TSH, but also for free T4, if you don't have reference intervals that are specific for your hospital, it does make sense to use a TSH upper limit of 4. But as we've also shown in studies that for the essence of time I will not go into, it is also similar to using a cutoff of 4 or deduct 0.5 milliunits per liter to just use the non-pregnancy TSH and free T4 reference intervals that you use for women who are not pregnant. Now, if you use the non-pregnancy reference intervals, this will slightly reduce the number of women that you diagnose with having mild thyroid disease, so mainly subclinical hypothyroidism or isolated hypothyroxanemia, and you will relatively increase the number of women that you would identify as having overt hypothyroidism or hypothyroxanemia, because it's likely that the free T4 cutoffs outside of pregnancy are slightly higher than they would be during pregnancy. But these differences are very small. So there's hardly any clinical consequences, and it makes your life a lot easier, of course. Another thing, and will also be mentioned in the new American Thyroid Association guidelines, of which I'm showing you a draft here. Another thing that you should really consider for women who have subclinical hypothyroidism in the first trimester, like Christine already alluded to, or in women who have overt hypothyroidism, where the TSH is less than 6 milliunits per liter, which is an arbitrary cutoff for identifying milder forms of overt hypothyroidism. What you can consider there is to recheck thyroid function within, for example, 3 weeks after first identifying the thyroid function test abnormality. And this is based on the data that I just showed you, with a high chance that the thyroid function will actually normalize when you retreat, or when you retest without treatment. So this is also something that you can definitely consider to introduce in your clinic. So just to conclude on this first bit, again, there's various ways of defining what is a normal TSH and free T4. And if you don't have hospital-specific reference ranges, it would probably be fine to just use your non-pregnancy reference intervals. Now, there's many cases of mild hypothyroidism that you're going to identify, especially if you screen women during pregnancy, that will spontaneously normalize upon remeasurement. So also consider to start remeasuring thyroid function within 1 to 3 weeks after the first blood test comes back abnormal. With regards to TSH screening, things I haven't mentioned, but are also an argument against doing this, is that you will identify many women with mild disease that will probably not benefit from treatment. There will be a very heterogeneous group with regards to disease definitions, as I've shown you. And of course, we also don't have any randomized controlled trial data showing that screening is actually beneficial. On top of that, there are new data coming out that are focusing on screening, that are trying to deal with these differences in reference range definitions and the heterogeneity that it causes. And one of the things that I like most is that the Danish are now coming up with studies where they're actually screening women for hypothyroidism in pregnancy, but only overt hypothyroidism. So they have developed this dichotomous test that basically says it's normal or abnormal for overt hypothyroidism. And that, of course, takes away some of the problems with universal screening, and which is identification of mild thyroid function test abnormalities, where we don't really know if treatment is beneficial or not. So they're only focusing on identifying the women that we are going to treat in any circumstance. So what to do with screening if you're not doing universal screening? Well, you can use the risk factors that we have identified for abnormal thyroid function test in pregnancy. Here you can see the current risk factors that are advocated to be used in the current ATA guidelines. And we are also going to update this bit a little bit. So I wanted to share that draft with you as well. And just to show you some of the things that we've been implementing here, when you focus on the italic or blue reference here, so a high age, multiple prior pregnancies, or morbid obesity, we've now done some new studies looking if age or maternal BMI or parity are actually associated with the risk of overt or subclinical hypothyroidism. And what we're able to do in our consortium is we do very large studies. So we typically find p-values that are statistically significant, just like we found for BMI, for example, as you can see on this slide. But what you can also appreciate from these data is that there are hardly any differences in the risk of hypothyroidism, and the same goes for subclinical hypothyroidism, according to maternal age, BMI, or parity. because as you can see for example, maternal BMI, is that the risk difference is about 0.2% from somebody with a BMI of 20 versus 40, right? So it's hardly any clinically meaningful differences there. So we've also done a big systematic literature review where we looked at all the possible risk factors that are reported on in the literature. And this is still data, this is still a manuscript that we are preparing for publication, hopefully within the next couple of months. But the conclusion of this work is going to be that in the current literature, there aren't any new clinically meaningful risk factors that we can implement for risk factor-based screening. So that was a bit dissatisfying, actually. So what we have come up with in the current draft, at least for the guideline update, is that we've removed BMI, parity, and also maternal age as a risk factor. And we've also slightly tweaked some other risk factors. For example, one of the things that we have added now is that we also mention specifically a postpartum thyroiditis in the past medical history as a risk factor. And we have further added some data on some of the other risk factors like infertility or having a pregnancy losses, where we now say that you don't have to check thyroid function in pregnancy if women with infertility or 2 or more pregnancy losses have already undergone thyroid function testing prior to pregnancy. So as I mentioned, I also had one final slide just to update you a little bit on postpartum care of hypothyroidism during pregnancy. We have some very interesting data that is follow-up data from the big New England Journal of Medicine trial from the NIH in the US, where they randomized women to be treated for isolated hypothyroxemia or subclinical hypothyroidism. But then in this new study, they followed up those women 1 and 5 years after delivery, and they measured their thyroid function, and they also asked them if they were diagnosed with hypothyroidism in the meanwhile. And what they found was that for women with isolated hypothyroxemia, only about 3% of them had hypothyroidism diagnosed postpartum, which seems really much in line with the general numbers you would expect for the general population. But for subclinical hypothyroidism, they actually found that around 13 to 15% of those women was later diagnosed with overt hypothyroidism. And this was even higher if there was TPO antibody positivity present together with subclinical hypothyroidism. So I don't think we should start to screen women who've had subclinical hypothyroidism diagnosed in pregnancy, for example, every year in the postpartum phase, because I think the yield of diagnosing it a bit more early than we are doing now is very limited. I do think it makes sense to counsel women who have had subclinical hypothyroidism during pregnancy about basically thyroiditis or hypothyroidism related symptoms. So, you know, the typical symptoms that we all are aware of that relate to hyper or hypothyroidism, just to inform women about these symptoms and that they can come in to get their thyroid function checked when they have these symptoms, and so that we can identify those who are at a high risk of hypothyroidism because of thyroiditis, or who already have hypothyroidism, for example, after 1 year of pregnancy. Other things that I would also like to remind you of, since I have a minute left, is of course that in the postpartum phase, it's important to consider to also start to also stop levothyroxine therapy for women who were not on levothyroxine before pregnancy, but were started on low-dose levothyroxine if they were diagnosed with, for example, overt or subclinical hypothyroidism during pregnancy. Because as I mentioned already, a lot of women will normalize their thyroid function already during pregnancy. So you really want to try and prevent that for unnecessary reasons. Women are stuck to the levothyroxine for the rest of their lives in worst case scenario. Of course, it's also important to realize that even women who have pre-existing hypothyroidism, so before pregnancy, can still get the thyroiditis after pregnancy. So again, discussing hyper and hypothyroidism symptoms also in this subgroup might be additive. And of course, for women who are on levothyroxine prior to pregnancy, after they've given birth, it makes sense to give them back their dose that they were using before pregnancy, because the pregnancy physiological changes that necessitate a dose increase are no longer present, of course, after they've given birth. So I'll leave you with some of my take-home messages on the screen, and Christine and I would, of course, be happy to answer any questions.
Thank you, Tim. Thank you, Tim, and thank you, Christian. And now I encourage people that are on our webinar to deliver the questions in the Q&A section. I've noticed there is one question already, and I'd like to ask you both. This is Dr. Suemi Marui. What is the TSH target in that patient with a previous hypothyroidism and is taking levothyroxine? Also, normal range.
So I think, as I illustrated on my first slide, so in women with pre-existing hypothyroidism, the target range is to try and keep that serum TSH below 2.5, because we know requirements will go up in pregnancy. And what we don't want is for problems to occur before we catch them. So the recommendation of starting when serum TSH is above normal, that's about starting in pregnancy. It is different if someone is already treated with levothyroxine, because we know that thyroid gland is going to struggle in pregnancy. So therefore, the target TSH is less than 2.5.
So I guess the question is mainly because we are changing our point of view now in a pendulary way. I think that in science, things tend to happen in a pendulary way. So before, in the previous guidelines, we had all these recommendations on treating patients, and that has got into the mind of all our physicians, even the OB specialists too, at least in my country, where they demand their patients to be on levothyroxine even if they have a TSH above 2.5, especially in the fertility clinics. And imagine when our new guidelines come out, the recommendations will be exactly the opposite, and it will take some change to move this into clinical practice. And so which is probably your idea of how this will get into the new activity of all these physicians that have their 2.5 as a set in stone, as Tim likes to put it.
Yeah, and I think generally change in practice takes time. I think, and I don't know if you have that in your country, but certainly here, what we do here is that fertility clinics, they say, well, your TSH has to be below 1 before you can become pregnant. So, and I think we're already getting a shift change that people are realizing, well, actually, no, there is no evidence for that. And, both Tim and I have shown the evidence. We have to practice evidence-based medicine. The cutoffs, as I said, and as we will say, are not absolute, and some interpretation can be required there. But we have to work with the data that we have, and with trial data, the retrospective data, and if there is no evidence to do that, plus a potential risk of harm, certainly trying to push those women to a TSH of less than 1, I think that is something that we need to take into account.
And talking about data, that since we are, of course, now stepping very hard on the data we have available, I wonder which is the data we don't have available. Or, I mean, Tim, which would be your ideal RCT, or which are the things that you think are not yet answered by the evidence we have right now?
Yeah, that's a good question. It's interesting to be on the other side of this question, because I always like to ask this to my PhD students as well, actually. So I think the main thing that I would want to know is the effect of isolated hypothyroxemia and subclinical hypothyroidism treatment in early pregnancy. Because as Christine has showed with a great slide, that there is quite a big difference, right, between the 1 positive trial and the 2 negative trials with regards to the start of treatment. And you know, honestly, the question is also whether it's really implementable, right? Because especially in many Western countries, women would only present for the first time to clinical practice when they are pregnant around, you know, 11, 12 weeks. So for the majority of those women, you won't be able to catch them on time if treatment would work. On the other hand, there's also a lot of places in the world where women do already present at 6 or 7 weeks, and where there can be a lot of benefits. So I think that's a big open question that I would personally go for if I had some unlimited funds for a trial.
If we were in an ideal world, we would do that, RCT, or perhaps in the future, because things are pendulary, as I say, maybe in 10 more years. And regarding so 14 now, which would be the ideal questionnaire a physician should have in mind if we don't have it in a chat or an app in our phone, like we have for instance, for osteoporosis, for cardiovascular risk? What we should have in mind when we approach a patient that is pregnant in order to screen if that patient really should have a TSH tested, or even a reflex TPO antibody test?
Yeah, that's a good question. And that's one of the problems with making a list of risk factors. And that is that actually, according to that list of risk factors, you need to do the screening and you need to remember it, which can be a little bit difficult to memorize. I really like common sense, and I think that most doctors who see these patients in pregnancy are very good doctors, and they are experienced with treating and identifying thyroid disease. So, you know, just thinking about common risk factors for thyroid disease is probably going to pick up the most relevant hypothyroidism, right? Because I really think that the women that we are missing right now that have a TSH above 10 at 12 weeks of pregnancy are the ones that likely have symptoms, likely had a thyroid abnormality before pregnancy, have known thyroid antibody positivity, have had head or neck irradiation, are using amiodarone, right? The main risk factors. And those are also the risk factors, unfortunately, that we don't have a lot of data for, right? We're just using them because it's common sense to use them. And the risk factors that we do have data for, and I've shown you some examples of that, are less meaningful. If you can just, you know, bear in mind that a general clinical assessment is important, and with some women that have these less common or less overt risk factors, you just refer back to the guideline table now and again, will probably allow you to do to identify.
So no app for the moment being. We don't need an app for this.
We are
Everyone
thinking,
on your
we are
phone.
thinking, we are thinking of making the dissemination of the guidelines easier by providing handouts and things like this. And of course, an app can be helpful, but on the other hand, if you're seeing 30 patients in one morning, like, you don't want to continuously keep opening up your app, right?
Okay. So I'm going to ask two questions since I'm waiting for questions, but until they come. It's a little bit confusing, the idea that we have some data on the risk reduction with levothyroxine in subclinical hypothyroid pregnant women for pregnancy loss rate, for instance. But on the other hand, the same studies show that there is increased risk of gestational diabetes or preeclampsia or low birth weight, and there have been several. Now there is one by Gao et al. in thyroid that reproduces in a retrospective study the same situation. So it might be overdose, but if it's overdose, how can we explain that on the other hand levothyroxine is avoiding miscarriage? So why do you think it has that dichotomous response, levothyroxine treatment?
Yeah, again, I think it's a good question. I don't know that I necessarily have the full answer to that. I do think that pushing free T4 concentrations to the higher end or above normal is associated with risk. I think none of these are trials, so they're, you know, they're not as controlled and as clean as a trial would be. A lot of this is sort of retrospective database study. And I think at this moment in time, we can only interpret it as there is a signal of harm. But again, when Tim does his nice trial starting levothyroxine early at 6 weeks of pregnancy, and we look at neurocognitive outcomes and obstetric outcomes, hopefully we'll get some better answers to that. But you know, I do think it's largely driven by pushing those 3 to 4 concentrations high. Why that would have a differential effect on different outcomes, I can't fully explain.
Yeah, I think it's important that to generalize that idea that over-treating also is harmful, because in the past years, that wasn't the case. I mean, we could treat and we could even lead the patient to subclinical hyperthyroid, I mean, status without any harms. And now there's good evidence that that is really associated to neurocognitive adverse effects, and also in pregnancy. So it's important that the new guidelines will probably reinforce the idea of avoid over-treating.
Yeah.
And there is one question that says, this target of 1 of TSH in women in fertility treatment is also with or without positive antibody? That's the question. You may expand on that, perhaps, and clarify the concepts.
Yeah, I don't think we have much time, but it's the same for with and without TPO antibodies, because we have all those trials of TSH in the upper half of the normal range with positive TPO antibodies in women seeking fertility, and they're all negative. So it's regardless of antibody status. That is not the dividing factor.
And I could keep asking questions, but I think that in honor of time, do you have any comments you would like to close with?
No,
You said everything, Tim, the last word.
No, I like I said, I think it's important that we don't follow guidelines to the letter, and just keep thinking about the patient that we have sitting in front of us, and trying to tailor our assessments and treatment management plans accordingly. And I hope that our future guidelines will be a way of structuring some lines of thought. Thanks for everyone's attention.
Well, I think the questions and answers is over, unfortunately. And I want to congratulate you both, because you are really a fountain of of science and knowledge. And it's very good to have you speaking and sharing your experience with us. So thank you again. Well, now we are coming to the end, and I would like to remind everyone that they have to complete the post-webinar survey in order to get the certificates. Also that many many persons registered for this webinar but couldn't assist, but there's going to be a recorded webinar available on the November 29th, and that all credits are going to be available on demand sessions until May 22nd. And so thank you very much. This also is part of a blended learning journey on thyroid disorders that you can check on the e-learning platform. You will find other activities too, which are already recorded there. And finally, you can follow us on social. You can get all our social media there. And also, well, I'd like to thank you very much for attending our webinar today, and say goodbye to everyone.